Hey, welcome back. Thank you for joining me today. The topic of the day is going to be antihypertensive drugs, a really important concept to understand, physiologically speaking, because hypertension is basically the definition of just elevated blood pressure, but it can be due to a lot of causes. It can be due to left ventricular failure, right ventricular failure, edema, excess fluid, pulmonary failure leading to cor pulmonale. There's a lot of reasons why you can have heart failure and hypertension as a result. That's more of a physiological phenomenon. You should look at my physio lectures about that. Today we're going to be concentrating on how to treat hypertension. It's dangerous because of the risk of strokes, myocardial infarctions, heart failure, of course. And it's dangerous because it's asymptomatic. So at first, the category of normal blood pressure is about less than 120 in young adults. It's elevated as you get older, so actually 120 to 129 is fairly normal in somebody in their 30s, not so normal when you're 17. This hypertension 130 139, that's when we start trying to get you on diet and exercising, but we really actually start getting worried when the blood pressure is 140 or higher. Okay, so the renin-angiotensin-aldosterone system is going to be overactive in patients with hypertension because of there's going to be some kind of feedback inhibition, so too much renin is going to be produced, and that of course goes into angiotensin 2, and that will increase sympathetic activity, increase the retention of water and the sodium, so there's going to be worsening of the hypertension thanks to this, along with the arteriolar vasoconstriction and antidiuretic secretion, leading to more more edema because of antidiuresis. So that's normally going to be stopping the kidney from producing renin, but in some cases, genetically, the kidneys just fail to respond. So as you can see here, it just kind of leads all the way back to the kidneys, which leads to the heart. Okay, so the classifications, we're going to begin with ACE inhibitors. Those usually end in pril. The most common drug used in the hospital is lisinopril. The angiotensin antagonist or angiotensin receptor type 1 blocker end in sartan. The most important one that we use is losartan. So this is going to block angiotensin receptor. Lisinopril is going to inhibit the ACE enzyme, right? So the calcium channel blockers are going to, of course, block the calcium channels. I believe it's the L type, and those end in dipene. So the exceptions are going to be verapamil and diltiazem. Unfortunately, these are really important to know, so you got to know them. The other ones that we do use are nifedipine, amlodipine, and klonopine. You probably heard of amlodipine. It's very commonly prescribed. Okay, other drugs we use to treat. We use the diuretics, the thiazide-like sparing drugs, and of course the potassium sparing. Why is that? Because too much potassium loss can lead to arrhythmias, worsening the heart failure. Beta-adrenergic blockers will end in lol, so propranolol, atenolol, bisoprolol, and acebutolol. These are the ones that are most commonly prescribed and used in the hospital. A good cheat is that selective beta blockers, so these are going to be selective for the heart. They're going to start with 8 M's, so atenolol to metoprolol are going to be selective. Non-selective would be N-Z. So propranolol is going to be non-selective. The other important ones you have to know are the alpha and beta 1 adrenergic blockers. So that is labetalol and carvedilol. These are important to know. These are dangerous to prescribe because you have to be very, very, very careful because of the dual action in the heart and in the blood vessels. Okay, so the alpha-1 adrenergic blockers are going to end in zosins. So prazosin, terazosin, doxazosin. The centrally acting sympathoplegic are going to be clonidine and methyldopa. And the vasodilators are hydralazine, minoxidil, and sodium nitroprusside. This is less important than hydralazine and sodium nitroprusside. The Dopamine D1 receptor agonist is going to be phenyldopa. This acts in the kidneys. And then a straight up renin inhibitor is going to be aliskiren. ACE inhibitors inhibit the conversion of angiotensin 1 into angiotensin 2. So this inhibits the enzyme. The other one inhibits the receptor, of course. But here it is. Without the angiotensin 1 being converted to angiotensin 2 cannot work on the sympathetic drive, can't work on the kidneys, can't work on the adrenal cortex. The vasoconstriction is not going to happen, and the antidiuretic hormone is not going to be secreted. So a pretty good drug. It's contraindicated, however, in pregnancies because it can cause too little amniotic fluid, which is oligohydramnios, hypoplasia of the organs, and teratogenicity, so not great for fetus. In adults, it can cause renal artery stenosis because, let's go back, in the kidneys, it actually works on a different receptor than in the arteries. So in the arteries, it will be like alpha-1. But angiotensin is going to work on a special kidney, keeping the capillaries and the arterioles in the kidneys open. It's going to vasodilate. So without it, it's going to cause the stenosis. So in patients with a predilection to stenosis is going to cause the acute renal failure because of the decreased glomerular capillary pressure. So with the dilation, it's not going to increase the pressure. We actually need the vessels to be somewhat constricted. It's also contraindicated in hereditary angioedema because of basically the same reason. Okay, so it can cause captopril. So ACE inhibitor ends in pril, so pretty useful mnemonic. First important one is going to cause a cough, a dry cough. And that's due to the C1 esterase deficiency, and the bradykinin is going to be able to act on the lung, and it irritates the lung alveoli. Angioedema or angioagranulocytosis is going to happen, proteinuria, potassium excess, unless you're treated with a diuretic that allows the potassium to be excreted. So in this particular case, we do not want to be giving potassium sparing diuretics. Taste change because of the angioedema of the lips and the tongue. Orthostatic hypotension. So remember, it's a reflex mechanism. You feel dizzy when you sit up or stand up too fast. Of course, pregnancy is the contraindication because of the fetal renal damage, along with anybody with renal artery stenosis and like kidney failure anyway. Here we go. And renal artery stenosis increases renin, and leukopenia will lead to the liver toxicity. So you have to be pretty careful. Okay, so the angiotensin receptor antagonist, so sort of works the same way as the ACE inhibitor, but works more like passively. Yeah. It blocks the enzyme, it blocks the receptor, not the enzyme. ACE inhibitors block the enzyme. And it blocks the type 1 receptors, and it has the same adverse drug reaction as the ACE inhibitor, so the renal artery stenosis, can't give it to pregnant females. On the plus side, there is no dry cough. Same contraindications, and you cannot combine the ACE inhibitors or the angiotensin receptor antagonist with potassium-sparing diuretics, like I said. So that's a no-go. Okay, let's see. Both the ACE inhibitors and ARBs will dilate the efferent arterioles, which are pretty good for the diabetics because for them, the vasoconstriction is too excessive. It's good. It allows the blood to flow, doesn't allow the deposition of metabolic byproducts, so there's not going to be any ischemia in the very, very tiny capillaries or the arterioles. And by allowing the blood to flow, it decreases the glomerular capillary pressure, which is good for these patients. Not so good for people with renal stenosis. Also decreases the proteinuria, protects the glomeruli. And then NSAIDs will constrict the afferent arterioles, which work against these. So you can't really use the ACE inhibitors and the NSAIDs together. Calcium channel blockers are going to dilate the arteries and arterioles, and they don't do anything with AV conduction. So these are just dilation. Diphenylacrylamine is going to be verapamil, and the benzothiazepine is going to be diltiazem. The dihydropyridines are going to be nifedipine, amlodipine, felodipine, isradipine, and nicardipine. Which one do you need to know? Amlodipine. Nifedipine has more adverse drug effects, so not as popular. We don't use that so much. Instead, we use amlodipine because amlodipine has a nice and long half-life, so you don't have to give as much medication. You can give the amlodipine like once a day in the morning and the patient is good to go. Now, as you can see here, let's see, the dihydropyridines are going to decrease systemic vascular resistance, so nice, brings down blood pressure, doesn't affect the heart, pretty good, and doesn't have any effect on the conduction, so pretty good. The non-dihydropyridines, we need to be careful with these because it can slow the sinus node rate, so slow the heart rate, and it can also slow the conduction. So this can be good in a patient with arrhythmia. So you want the heart rate to slow down and for the heart to contract more efficiently, but this decreases the contractility. So be careful with these kind of drugs. Okay, so how do dihydropyridines work? Binds and blocks the calcium channel. And yes, it's the L-type calcium channels in the heart and smooth muscles and the arteries. Good thing is that verapamil is more selective to the heart, so your skeletal muscles are not effective. So the skeletal muscles are still able to contract. Diltiazem is intermediate between heart and vascular smooth muscle. Nifedipine is more selective to the vascular smooth muscle. Like I said, we don't really use this in a clinical practice. This is more on academic level. You will be tested on it, so it is important to know. Let's see, used for conditions that are leading to vascular resistance, vasoconstriction, hypertension, Prinzmetal angina, Raynaud's syndrome. We'll go through that eventually. Okay, let's see. The adverse drug reactions. They are, here's a nice little mnemonic. Very nice drugs. So verapamil, nifedipine, and diltiazem. Some of these you can deal with, like flushing. Some of these, not so good. Bradycardia and dizziness. Verapamil will cause constipation. That's not very nice at all. And nifedipine is going to cause angioedema along with gingival hyperplasia. So the gums are going to overgrow. Contraindicated in people with systolic heart failure and atrioventricular block. Why? Because it slows the contractility, decreases the conductivity of the heart, and can increase the arrhythmia. Okay, so beta blockers and then LOL. they will decrease the stroke volume and the heart rate by increasing the cardiac output. So it decreases the renin secretion, decreases angiotensin 2 and aldosterone. So with the renin secretion, blood pressure is going to go down. Nice. Decrease angiotensin 2. It's going to, of course, not act on the kidneys, the adrenal gland, the pituitary gland. Pretty good. Also decreases the blood pressure. And aldosterone is going to, with a decrease of aldosterone, there's not going to be as much water retention. However, there are some central nervous system effects. There's fatigue, lethargy, insomnia, and hallucinations. Otherwise else, it also decreases the libido, sexual dysfunction in males, exercise intolerance by disturbing the lipid metabolism. So you're not going to have a lot of energy, or not as much energy. There's a problem with lipid breakdown. However, it also hides the signs of hypoglycemia. So you're not going to have the tremors, you're not going to have the dry mouth or the paleness. Problem is, if you stop it too soon, you can have the rebound hypertension. So when you stop it too suddenly, the hypertension comes back, but worse. The non-selective propranolol and nadolol, of course, should never be used in asthmatic patients or patients with peripheral vascular diseases because of the constriction effects. You'll make it worse. Patient will die. Nebivolol will make nitric oxide. Metoprolol and atenolol are not going to be good to use in heart failure and peripheral vascular disease because they are going to be atenolol is not going to be selective. So these are going to be non-selective, not good. We don't want to use it. Cardioselective beta blockers, gotta know them. Nice mnemonic here, man babe. So metoprolol, atenolol, nebivolol, bisoprolol, acetobulol, betasolol, and esmolol. Esmolol is really important. It's also used in it's also used as a diuretic. Okay, so the beta receptors, beta 1 because of one heart, and beta 2, 2 lungs. So this is actually a very, very useful thing to know. Okay, so beta and alpha 1 blockers are the second line drugs. Why? It's dangerous. You would be targeting both heart and vessels, of course. Carvedilol is mainly used to treat the hypertension and heart failure. Labetalol is going to be the first in line to use in gestational hypertension because it doesn't cross the placenta. Good stuff. Other ones that you need to know: nifedipine, methyl-dopa, and hydralazine. I remember it as labs hide meth knives. Crazy, but you'll never forget it, right? Of course, ACE inhibitors, AKBs, and diuretics are going to be contraindicated in the pregnant females. Alpha 1 blockers are going to be your second line drugs. First line is going to be ACE inhibitors, then beta, and then the alpha 1 adrenergic blockers. Prazosin, terazosin, doxazosin, and tamsulosin. Tamsulosin is nice and special because it is going to be used to treat hypertension in males, so patients with benign prostatic hyperplasia. I'm uncool for saying that. Sorry, the adverse drug effects would be reflex tachycardia and the postural hypotension. There's also going to be edema. Clonidine and methyl-dopa are alpha 2 receptors, and that decreases the sympathetic outflow. Risky because whenever you deal with the sympathetic outflow, you can affect a lot of things. So these drugs have to be monitored quite closely. Clonidine does not decrease renal blood flow or glomerular filtration, so it leaves the kidneys alone. And the adverse drug reaction are going to be the rebound hypertension, the sedation, constipation, impotence, and bradycardia, because it's working on the alpha 2 receptors in the brain, so like the vagal nerve. And methyl-dopa will cause the sedation and drowsiness, and in overdoses, you can see it in a positive Coombs test. So, since it works in the sympathetic outflow, like I said, it works in the vasomotor center in the hypothalamus. So, hypothalamus controls a lot of basic functions that we need to live. Okay, so hydralazine and minoxidil are going to be your second line anti-hypertension drugs as well. And the important one you got to know is sodium nitroprusside. So those are going to be used in hypertensive emergencies in order to dilate both the arteries and the veins. Hydralazine will work by releasing nitric oxide. Unfortunately, it can have water and sodium retention, and that leads to edema along with tachycardia to kind of like increase the cardiac output to match the edema. Hydralazine and beta blockers are going to be used together to treat gestational hypertension. And the adverse drug effects of the vasodilators are going to be the headaches due to the dilation of the vessels in the brain, and that will press on some sensitive structures. Tachycardia, angina, lupus-like syndromes, so the fever, the rash. The minoxidil will cause the hyperpolarization, dilate the arteries, and hypertrichosis. So it's going to increase hair growth, and it can be used to treat baldness. Okay, so back to sodium nitroprusside. It's going to work by releasing nitric oxide, and that is going to be free nitric oxide. There's no need for endothelium. And it decomposes at alkaline pH and light, so it is pretty fragile. That's not right. Sensitive? It has to be handled quite carefully. Monitor this drug because the adverse drug reactions include cyanide poisoning and lactic acidosis. So these are the ones we gotta be careful about. Remember, in cyanide poisoning, cyanide will bind to the hemoglobin, creating cyan-methyl-hemoglobin, and that's an oxygen trap. So how do we treat it? We got to give them methylene blue in order to oxidize the methemoglobin back to plain old hemoglobin. So in an overdose of sodium nitroprusside, you want to give nitric oxide nitrite, sodium thiosulfate to chelate, or hydroxycobalamin. Easy. Always go for the hydroxycobalamin. Okay, so the dopamine D1 agonist, phenoldiprem, is going to be used also to treat the hypertension emergency. The renin inhibitor aliskiren will just directly inhibit renin. It's effective, but there's a lot of really bad adverse drug reactions. So the diarrhea can lead to massive like extracellular volume loss, and the hyperkalemia, of course, can lead to the arrhythmias, which can lead to myocardial infarction or a stroke. Sildenafil will treat the prostatic hypertension and is a phosphodiesterase 5 inhibitor. Bosentan is going to also treat the same thing. However, it's an endothelium antagonist. And epoprostenol is going to be a prostaglandin 2 analog. So that's going to increase the vasodilation. Okay, so compensation. Thiazide, loop agents, beta blockers, ACE inhibitors, and ARBs have minimal response. So in central acting antagonists, such as and nitroprusside, there's going to be water and sodium retention. So with the alpha-1 blockers, hydralazine and minoxidil, those are also going to have the sodium and water retention along with tachycardia. So the safest ones are the drugs with the least amount of adverse drug effects. So they're going to be this top line. This is why these are the first line drugs. Okay, so how do we manage hypertension? Diet and exercise first. Try to manage the lifestyle, and then we start with one drug, and then Those will either dilate the vessels, is a diuretic, or targets the heart selectively. What do we use? ACE inhibitors, alpha-1 antagonists for the vessels, calcium channel blockers for the heart. There's a guideline we follow, is the JNC, and so first it's going to be, of course, lifestyle changes, and then based on like the ages and whether the person has chronic kidney disease, that's what we look at in order to prescribe. It's not a hard and set rule, but like it's useful to guide you. You still have to talk to the patient, take their patient history, and kind of see how their metabolism works with these medications. But these are pretty helpful hints to kind of like, guide you along your way. So angina, we want to give ACE inhibitors, beta blockers, and calcium channel blockers to lower the blood pressure, slow the heart rate, decrease the contractility. And all of that decreases the workload on the heart, decreases the oxygen demand, relieving the chest pain. For diabetes, ACE inhibitors or angiotensin receptor blockers. These don't treat the diabetes. I should have worded that better. This is for diabetic patients. So with the other drugs, they can have some adverse effects on metabolism, but ACE inhibitors and angiotensin receptor blockers will not. For heart failure, you use all of these along with your spironolactone in order to spare the potassium. Post myocardial, we give beta blockers, ACE inhibitors, or ARBs in order to prevent recurrence. And of course, benign prostatic hyperplasia, tamsulosin. Just remember tamsulosin. Dyslipidemia, you can give either ACE inhibitors or ARBs, calcium channel blockers, or an alpha blocker. Chronic kidney disease, more importantly, you use the ACE inhibitors or ARBs. We don't want to play around with anything that really touches the kidneys. We want something just to like handle the blood pressure systemically. And in pregnancy, meth hides lab knives. There we go. Okay, so a hypertensive emergency is something like hypertension, which is going to lead to target organ damage. You want to use sodium nitroprusside, and you inject the IV. The mean blood pressure has to be lowered down slowly. It can't be lowered by more than 25%. And you want to keep it at 160 over 100, even though that sounds crazy high, because of the cerebral hypoperfusion. We can take care of the strokes. We can't really deal with the ischemic brain. So after the patient has been stable, you ship them to a rehab hospital and let those physicians lower down the blood pressure to something reasonable, but it takes them 2 to 3 weeks. Okay, more managements. So you want to give the patients nitric oxide vasodilators, such as sodium nitroprusside when it's critical, nitroglycerin as management and for symptomatic relief, calcium channel blockers, nicardipine in a neurologic emergency, so when the patient is unresponsive and slipping into a coma, and clofidipine, adrenergic receptor antagonists. You want to give them phenoltamine, esmolol, and labetalol. And for the vasodilator, you give hydralazine, so it can work on both the arteries and the veins. And then, of course, dopamine agonists, you give them phenoldopa. So first, we want to examine patient for evidence of end organ damage. So we're looking at this. First, we start with the oral agents, and then we start with IV first in an emergency. Then you treat with the oral agents. Okay, so resistant hypertension is a problem that has been increasing here in the States. It's getting harder and harder to treat. So the blood pressure is not responding to one drug anymore. Nowadays, it's the 3-drug regimen that includes a diuretic. So what causes it? Excessive alcoholic intake. That causes the fatty liver changes, a cirrhotic liver, diabetes, hyperaldosteronism, so some kind of metabolic syndrome. Diabetes will cause it. Some medications such as sympathoplegics, nonsteroidal anti-inflammatory drugs, and antidepressants. If all else fails, and and they're not responsive to any kind of medication, you always have to consider pheochromocytoma. So this could be a cancer, increasing the adrenal hormones, of course. And in these patients, not only is their blood pressure high, but their heart rate is also like racing. Okay, so that's it for now. Thank you for your attention, and burn this in your mind, because this is a really, really important concept to know, and all the medications are really important, because as a clinician, you will have to use these in the future. All right, that's it for now. My computer is dying. Keep studying.